So, good afternoon, everyone. Welcome to the day two's classes. So, we'll be continuing with topics from hematology, which we had started yesterday. So, we will be continuing with the next topic that is heparin-induced thrombocytopenia and thrombosis. This is one of the questions they quite commonly ask. Okay, so coming to the outline of the topic, I'll be discussing under the following headings: its definition, pathophysiology, clinical features, diagnosis, management, and new modalities. Okay, so the most of the illustrations that I've used in this presentation is directly from an article from ISTH. Okay, so I will be sharing the details of the article in the end of the slide, so you guys also can go and download that article and read. Okay. So, heparin-induced thrombocytopenia and thrombosis is defined as an immune-mediated adverse drug reaction, which is an event occurring after an exposure to heparin that results in thrombocytopenia and potentially catastrophic thrombosis. Okay, so it is nothing but an immune-mediated adverse drug reaction that causes thrombocytopenia, catastrophic thrombosis. The incidence usually it is majorly seen in cardiac surgeries where the use of heparin is very high. Okay, major cardiac surgeries, and it is seen in 1,500 hospitalizations from the US data. It is seen both in unfractionated as well as low molecular weight heparin. Having said that, the proportionality of incidence is higher in unfractionated heparin as compared to low molecular weight heparin. What they have found out is if the exposure of heparin is usually a shorter period, then the possibility of development of Hitt is also lesser. Okay. So coming to pathophysiology of heparin-induced thrombocytopenia and thrombosis, we all know heparin, either it is unfractionated or low molecular weight heparin, both are negatively charged polysaccharide chain, which has an anticoagulant property. When this merges with the platelet factor 4, which has been released from the alpha granules of an activated platelet, they form a neoantigen because this platelet factor 4 is a positively charged chemokine. Okay, so a negatively charged heparin, a positively charged chemokine like PF4, they combine together by electrostatic interactions to form a neoantigen, which is called as the Hitt antigen. And we all know whenever there's an antigen, the immune system gets activated and an antibody is formed. Okay, so the antibody which is formed to this neoantigen, that is your Hitt antigen, is called the anti-PF4 heparin antibody. Okay, and this causes all the catastrophic events. Okay, this is the immune mediated adverse drug reaction to heparin. Okay, so this is the baseline or the initial trigger event for heparin induced thrombocytopenia thrombosis. So once this antibody forms, how does it cause thrombosis and thrombocytopenia? So we will know about that in the further slides. So we all have to know Hitt is an immune mediated reaction which usually occurs from 5 to 10 days after the exposure of heparin. It is triggered because this neoantigen is formed by heparin and platelet factor 4, and it causes release of platelets and it makes them activated platelets. Okay. So usually the type of antibodies which are produced against the neoantigen, that is the heparin PF4 complex, is an IgG type of antibody, and these are the culprit antibodies. Okay, compared to the other type of antibodies like IgA, etc. Okay. So IgG antibodies usually form immune complexes along with heparin and PF4 complex. Okay. So how do they form that? These immune complexes bind to the Fc gamma 2A receptors on the platelets. Okay. So the Fc gamma 2A receptor is present on a platelet, and this platelet would be converted to an activated platelet. And what does happen when we have activated platelets? It is definitely going to cause procoagulation. Correct? How does it do? It will release more factors, granules, aggregations, etc. Correct? So this causes a self-amplifying loop. Okay. So how does it cause thrombosis? It causes it by widespread activation, aggregation, and consumption. And because there is consumption of platelets, there will be thrombocytopenia. And because the platelet granules are releasing a lot of chemokines, it turns it into a procoagulant state. Okay, the tissue factor, etc. All of this would get activated. And because there is a procoagulant state which has been triggered by this immune response, it causes thrombosis both in the venous as well as the arterial system. Okay, and this thrombosis occurs despite a falling platelet count. Okay. So the next part of this is, with all this immune mediated reaction happening, a lot of endothelial damage being present, it just triggers a vicious cycle. And this contributes to a lot widespread multi-organ dysfunction. Okay. The paradox of HIT, that is heparin induced thrombocytopenia and thrombosis, is there is thrombosis and not bleeding despite the platelet counts being low in cases who have developed this adverse drug reaction. Okay. And the main important thing is you need to stop heparin because that is the driver of all this thrombogenic cascade. Otherwise, this patient can have risk to limb or even life. The next important question is, earlier I told you the neoantigen produces antibodies, and most of the times IgG type of antibody is what is produced majorly, and this goes and activates the FC2A, FC2 gamma receptors on the platelets, correct? So do all types of antibodies do it? No. Okay. Usually the IgG type is the one which causes the uh, immune response. Okay. Other things like other immunoglobulins like IgM and IgA rarely cause hit. Okay. So if someone asks you in a practice what type of it is, it usually you have to mention it is the IgG type. Okay. IgA, IgM do not cause it. And why do we talk about IgG? Because usually they are ultra large molecular complexes, and these are the ones which have the higher propensity to cause immunogenic reactions. Okay. So this is one practical question that I want you to remember. Okay. So this is about pathophysiology of heparin-induced thrombocytopenia and thrombosis. Coming to the clinical manifestations and outcome, we all know thrombosis is usually the major manifestation of HIT, and it is one of the important criteria for the diagnosis as well. Okay. So usually whenever you have a patient who has undergone a major surgery or has been exposed to heparin for any reason, and then you see a drop in platelet count, then you have to look in all these manifestations. Okay. If you've looked into the patient's details history, okay, and then you examine the patient and look at the laboratory parameters, if they are correlating, then you have to have a suspicion. So in clinical examination, what do you find? Thrombosis, majorly arterial or venous, both are present. Okay. So venous is predominant as compared to arterial most of the times, but both can be present, and the risk of development of thrombosis is as high as 60%. Some patients can have bleeding. Limb loss would also be there, usually because of a thrombotic event. Okay. Unexplained loss, then on evaluation we would know that. Worst case scenarios, the patient can have increased mortality and length of stay in the hospital. Okay. Rarely these heparin-induced thrombocytopenia and thrombosis can mimic DIC or necrotizing fasciitis like lesions. Okay, so few anaphylactide reactions can also mimic HITT. Okay, so these are the DDs that we need to remember in the initial phases when we are working up for HIT. Okay, so ideally look for history, exposure, duration, then these clinical manifestations. Okay, so coming to the diagnosis, there are two prerequisites which are required for diagnosis of HIT. Okay, one, the patient must exhibit a clinical picture consistent with HITT. Okay, along with this, the patient should have heparin dependent antibodies, and that antibodies must be platelet activating. Okay, sometimes they might have drug reactions. Okay, so that should not be always attributed to HIT. Okay, it should be platelet activating, so much so that this causes some amount of thrombosis or an immune inflammatory reaction. Okay, so this is when we come to a diagnosis that this patient has developed HITT. Okay, so how do we approach? So always we have a clinical suspicion followed by an objective assessment, and the objective tool that we use for HITT is the 4T score. So what are the components of 4T score? We all know it's thrombocytopenia, timing of platelet count fall, thrombosis, and we have to primarily rule out all the other causes of thrombocytopenia. So usually all these constitute the 4T score. Coming to the individual parameter, how do we score them? Usually 0, 1, and 2 is what the scoring is. 2 is the highest and 0 being the lowest. So whenever there is a platelet fall of more than 50% or the platelet nadir drops for more than 20,000 cells per liter, then the patient is scored as 2. If the drop is between 30 to 50% or the nadir is less than 20,000, then the score is 1. And if the platelet fall is less than 30%, then probably it is unlikely. So that gets the score of 0. Coming to the second component of the 40 score, that is the timing. Always remember the fall, especially when we are suspecting HITT, usually is between 5th to 10th day. Okay. Here, if the patient has developed thrombocytopenia after 5 days of exposure to heparin, then you can score this patient as 2. Or else, if the patient has a sudden drop on admission itself, please look into history of exposure to heparin within the last 30 days. Okay. Even in such cases, this patient can develop heparin induced thrombocytopenia thrombosis. So most of the times we try to omit this part. Okay. Always look into it. Thrombocytopenia, we have to keep it in our mind. Okay. You have to rule out all the other causes definitely, but yes, always ask for heparin exposure also whenever you feel this patient has thrombocytopenia, which is not usually due to any other cause like sepsis, etc. Okay, or any other cause of hematological diseases. The next point is if the platelet fall is less than 5 to 10 days, okay, or else it's after 10 days, or it is between 30 to 100 days of exposure, then the patient gets a score of 1. If at all it is less than 4 days, definitely it is unlikely to be HITT. Remember, 5 to 10 days or less than 1 day with the prior exposure to heparin within 30 days is 2 points. Okay. Coming to the next point, that is thrombosis or other sequelae. New thrombosis, be it skin necrosis, systemic reaction, okay, post IV fluids, sometimes even places with old CVC sites, okay. So even those places also, if there are skin lesions that you see, they can be the harbinger for event, and they can give you a pointer towards the diagnosis of HITT, okay. So always rule out all these things and always ask for history. Okay. So thrombosis is one of the important criteria for the diagnosis of heparin-induced thrombocytopenia thrombosis. Okay. Obviously, other causes of thrombocytopenia have to be ruled out, and when there are none available, then we can give this patient a score of 2. Okay. And if you find there is a definite possibility of thrombocytopenia for some other reason, then they get a score of 0. Okay. So this is the 4T score. Okay. So coming to the total, a probability of HITT is calculated by the use of 4T score. If the score is more than or equal to 6, there is a higher probability, that is roughly around 64%. If it is between 4 to 5, it is intermediate. If it is less than or equal to 3, it is a low probability. Okay. So we know if it is low, we have no issues. What do we do for intermediate and high is what the next question is. Correct? How do we treat this patient? Intermediate group of patients and high risk patients. Is 40 score the only score? No. Okay. So there is another score called as the HEP probability score, that is the Hitt expert probability score. Again, here also more than 3 and less than 3 is what is considered. If it's less than 3, unlikely. More than 3, it is intermediate. More than 6 is again definite HITT. Okay. So can we label any patient with a score of more than 4 is equal to HITT? Unlikely. Okay. So you have to rule out all the other criterias. Okay, individually you have to look into the thing. Okay, and check for heparin exposure, and after doing the 40 score, do a confirmatory test. If it is between 4 to 5, it's always a plus minus. Okay, so this is always supposed to be followed up with a confirmatory diagnostic test. More than 6, it's high probability. Okay, if you do or you don't do, definitely we will come to a diagnosis of it. Okay, but in the intermediate group, usually in our clinical scenarios, we end up using this kind of patients. Correct. So in these patients is where we have to do the confirmatory tests. Okay. So if the patient has one of this, you need to look for Hitt antibodies, and if Hitt antibodies are present, then you can diagnose this patient as having HITT. Okay. So what are the confirmatory tests and how do we go about them? So we know we need to find out the antibodies to the heparin platelet factor 4 complex. Correct. So there are two types of lab diagnosis which helps us come to a diagnosis, which is a confirmatory test. Okay. We have the immunoassays, we have the functional assays. Immunoassay is one of the earlier tests that we need to do. Okay, it is a test which is done to determine if anti-platelet factor 4 heparin antibodies are present. And if it is present, based on the optical density, how much is the abundance of it? That is how it is going to be done. Okay. Remember, immunoassay is first, it will let us know if there is an antibody present or not. And if it is present, how much is present. Okay. So these two things can be understood by the use of enzyme immunoassay, and by then we can also confirm that this patient has antiplatelet 4 heparin antibody. There are other tests that we usually can do. Okay, what are the other tests in enzyme immunoassays? Particle gel immunoassay, IgG specific chemiluminescence assay, lateral flow assay, and lateral turbidometric assay. You need not remember all the things that are present in the slide. Just remember the names of it. It's more than enough. Okay. So you just have to know what are the tests which are usually sent. Okay. So the tests usually majorly, you see, they all detect IgG type of antibodies. Okay. So this is the reason that I have told you. Okay. So, what is the conclusion of doing an immunoassay? If enzyme immunoassay is positive, you can proceed with a functional assay, okay, and then give the confirmation that this patient has HITT. If the EIA is negative, it essentially rules out that this patient has HITT. How does it rule out? Because it is directly telling you that there are no heparin-induced antibodies which are present with the patient. Okay, so this is the first step in confirmation of HITT. That is your enzyme immunoassay. So coming to summarizing till now, we looked at the definition, pathophysiology, and then we looked at the clinical features. After the clinical features, we wanted to do the objective assessment. Based on objective assessment, we use the 40 score, and then we have a score 4 to 5 and more than 6. 4 to 5 is intermediate, more than 6 is almost definite. 4 to 5 is where we had this trouble, right? Whether the patient has or no. Then in that case, we have to get a confirmation. In confirmation, we do two tests. One is a functional assay and an immunoassay. Immunoassay is the first step in that. Okay, so immunoassay will tell us if there are antibodies present or absent, and based on that, the next test is if the antibody is present, whether it will trigger the platelet is what will be told by the serotonin release assay. Remember earlier I told you Hitt is only diagnosed once this antibodies are present, and this antibodies should trigger the platelet activation, causing all the thrombotic cascade. Okay, so that is the whole idea and understanding of HITT. So coming to the next step in laboratory diagnosis, that is the functional assay. So we have the serotonin release assay, that is your carbon 14 serotonin release assay. This is the gold standard functional assay. So what do we mean by functional assay? Here, it will help us determine whether the anti-PF4 heparin antibodies are pathogenic. That is, whether they activate the platelet or not. Okay. So this is step 2 in confirmation of the HITT. Okay. So there are other functional assays which are present apart from the serotonin release assay. But if they ask you what is a gold standard test for HITT, then you have to tell it as serotonin release assay. Okay, so which are the other functional assays? Heparin-induced platelet activation assay and P-selectin expression assay. Okay, remember two words: immunoassays, functional assays. Functional assay is serotonin release assay. So why does it become necessary? That will be helpful for you in this slide. Okay. So if you are having a patient with, a score between 4 to 5 and 6 to 8, you see what happens to the probability of diagnosis. If you see the right hand side, you see that majorly the diagnosis does not change. The sensitivity more or less is good enough, in a patient who has a 40 score of more than 6. But 4 to 5, with the use of immunoassay and optical density, as the optical density becomes more and more, the probability of diagnosing HITT becomes better. So this is how enzyme immunoassay helps us come closer to a diagnosis of HITT. So summarizing the whole thing, clinical suspicion, 40 score, categorize the score, okay, low, intermediate, high. Intermediate or high, you can go ahead. First step, whenever you have a 40 score between 4 to 5, the first step, stop heparin if the patient is on heparin, okay? And also think about using an alternate anticoagulation strategy for that patient if at all it is necessary. Okay, so that is the first and foremost step whenever you are thinking of HITT and you have come to a score of probably between 4 and above. Okay, so intermediate to high. The first step is stop the inciting factor. After doing that, go ahead with your screening test, then come get your confirmatory test to come to a diagnosis of HITT. Okay, how do we manage these patients? So first thing I already told you, stop the inciting trigger, that is your heparin, and if at all the patient needs anticoagulation, use an alternate strategy. Okay, why is it necessary? Why is it like any other drug reaction? If it is immunogenic also, if we stop the drug, we should be all right, right? So why do we have to do this? The major reason is because even after we stop heparin, there's always a risk of this cascading effect, that is the thrombogenic foci, which is being present in the body to continue for a longer period of time. Roughly, what they say is it's up to 4 to 6 months and above. Okay, so because there is always a risk of thrombosis which can occur despite cessation of the drug, that is the reason we need to start this patient on anticoagulation strategies. Usually, what happens is monocytes bind to the platelet factor 4, wherein they start the prothrombotic cascade. Okay, so the two key principles in head management: first, avoid heparin; two is anticoagulation strategy. Okay, so now you have understood why we do it and what are the things that we have to do. Okay, so the use of non-heparin anticoagulation is what we are looking forward. Okay, so where do we need them? Okay, and how long do we need them? Okay, so this is the next algorithm that you need to look into. Okay, if a patient has clinical thrombosis, okay, which is present, be it in limbs or anywhere else, be it in the venous system or in the arterial system, definitely this patient needs an anticoagulation for 3 to 6 months. If there is no clinically apparent thrombosis, then you have to do certain other tests like your compression ultrasound, DVT scan, etc., and also look in for sites of venous access like your cannulas, CVCs, okay, and arterial lines, etc. All of this accesses also have to be looked into. If a patient has received any such access in the last 5 to 10 days or even a month, look at all these accesses and rule out potentially any thrombus which is present there. Okay, if at all nothing is present at that time, you have to continue anticoagulation until platelet recovery. Okay, so first thing, stop heparin. Second thing, start anticoagulation which is not heparin based. And how long, it depends on presence or absence of thrombosis. If there is thrombosis, 3 to 6 months. If there is no thrombosis, then continue until platelet becomes normal. Okay, so that gets categorized as Hitt, subacute Hitt A. Okay, I'll show you the next slides where you will understand what are the categories. Okay, so this is basically what you need to write about management of heparin-induced thrombocytopenia and thrombosis per se. Okay, so do all these patients require, so you're still testing, you have not got your serotonin release assay, you have not got your enzyme immunoassay. Usually all of them have a very short turnaround time, but still, so whom do you think that these patient needs closer follow-up in? If platelets are dropping, okay, and you feel that the patients are at a low risk category, probably you need not repeat doing it. Okay, if the patient falls in the 40 score between intermediate to high risk, probably you have to repeat a platelet count as the frequency is mentioned. In intermediate groups, roughly every 2 days. In a high risk group, you have to consider doing platelet count every day. Okay. So along with this, the table below gives you alternates for unfractionated heparin, because I told you earlier unfractionated heparin has a higher probability of developing Hitt, right? So in each particular scenario, what can be used is what they're telling. So what they say is use of fondaparinux is unlikely to cause heparin-induced thrombocytopenia and thrombosis. Okay, again, if you see unfractionated heparin, definitely it can cause. Based on medical and surgical patients, you need to switch between LMWH and fondaparinux. Coming to Hitt phases and management. Okay, so I told you earlier, right? In management, there are two things. Okay, how long we have to give anticoagulation. So thrombosis is there, 6 months for sure. If thrombosis is not there, until platelet recovery. And I told you that is subacute Hitt A type of patients. So how do we categorize them, and how do we categorize the phases of Hitt? Okay, so initially, when the patient is suspected to have Hitt, the only thing that we know here is the platelet count is low. We do not know about the functional assay, enzyme immunoassay, and we don't know the thrombosis risk as well. As and when we start getting the tests, we categorize the patient as development into acute Hitt. In acute Hitt, we know there is low platelet count, functional assay is present, and enzyme immunoassay is also present. Okay, so it's not particularly in that order, but it should be enzyme immunoassay and functional assay. And because of both of them being present, there's an increased risk of thrombosis. And these group of patients fall under acute Hitt. So as soon as you get the diagnosis of acute Hitt, first thing stop heparin, second start anticoagulation, which is not heparin based. Okay, and then once the patient starts becoming better, the platelet starts improving, then the patient reaches a baseline platelet count of more than 1 lakh, they get categorized as subacute Hitt A. Okay, in subacute Hitt A, if you still do a functional assay or an enzyme immunoassay, you might still see some antibodies being present. Okay, slowly as time progresses, they get converted into subacute Hitt B and remote Hitt. Okay, roughly it takes up to 1 month for things to come to baseline. Okay, so this is the phases of Hitt. Okay, if you don't remember, it's okay. All that I want you to remember is the slide here. Okay, so this is basically about why I had to mention about subacute Hitt A there. Okay, so remember with thrombosis, without thrombosis, what you do. That's more than enough. Coming to choosing the anticoagulant. So I kept telling you stop heparin, start something other than that, right? So what are the options that we have? We have oral 10A inhibitors, vitamin K antagonists, argatroban, bivalirudin, danaperoid, and fondaparinux. Okay, and the route of administration is also given. Okay, so how do we choose the anticoagulation which is non-heparin based? Is depending on the liver dysfunction, renal dysfunction, and the clinical stability of the patient. Okay, one glaring thing that we look here is vitamin K antagonist. Okay, despite it being a non-heparin anticoagulation, there is no indication that this agent is not recommended because vitamin K itself in this particular phase of it can cause thrombosis. Okay, so that is the reason there is no role for warfarin in HITT. Okay, I'll be discussing about this in the further slides. Okay. So, coming to individual drug, I told you how do we choose them based on clinical stability, life or limb-threatening ischemia, hepatic dysfunction, or liver dysfunction. Okay, so we all know if there is renal dysfunction, we can use argatroban. If there is liver dysfunction, we can use bivalirudin. Okay, so these are the two IV anticoagulation strategies that we can use, especially with patients with renal dysfunction and liver dysfunction. Okay, so just keep that in mind. Remember, few of the anticoagulations are oral, few have to be given as IV infusions, and fondaparinux is given as subcutaneous injection. Most of the times, you might have to start this patient on an IV infusion. Probably you have to start this patient on argatroban or bivalirudin. As time progresses, you can discharge the patient on oral anticoagulation or a subcutaneous injection. Okay. So when we do that, I'll discuss in the further slides. But firstly, what are the advantages and disadvantages over the other is one thing you have to know. Okay. So IV infusion always it requires a monitoring. Okay. Otherwise, there will be a probability of overshooting, right? So that is one thing that we need to keep in mind. Okay. So most of the times we start with bivalirudin or argatroban, and the dose for bivalirudin, if organ functions are normal, okay, even if there is hepatic dysfunction, you can use this. Okay, it's around 1.15 milligrams per kg per hour. And argatroban, the dose is around 2 microgram per kg per minute. Okay, and this has to be adjusted based on organ dysfunctions. So once the patient starts improving, then you can switch over to oral. What are the oral drugs which are available? Rivaroxaban, apixaban, and dabigatran. Rivaroxaban or apixaban, the dosing you have to remember again in acute phase up to 1 month. Rivaroxaban, it's 15 mg twice daily for 3 weeks, and then you reduce it to 20 mg once daily. If it is without thrombosis, that is isolated hit, you give 15 mg twice daily until platelet recovery. Okay. So remember, with thrombosis, I told you up to 6 months, right? So it has to go till there. If it is isolated, only till platelet recovery. So in both the places, you have to remember the dosing. Okay. If you can recall, well and good. Otherwise, just mention the name of the drugs. Okay. Don't get scared. It's ideally that we need to know it, but yeah, it's hard to remember. Okay. Similarly, remember one drug, that is more than enough. Either remember rivaroxaban or apixaban. Okay. And then you have to remember where it cannot be used. So apixaban, on the other hand, whenever there is hit with thrombosis, it starts with 10 mg twice daily for 1 week, then followed by 5 mg twice daily till 6 months if there is thrombosis. If it is isolated hit, 5 mg twice daily until platelet recovery. Okay, remember one of these two things. Okay, so I feel apixaban is easy, 10 mg twice daily for 1 week, followed by 5 mg twice daily with thrombosis. If it's isolated, 5 mg twice daily till platelet recovery. So, what are the precautions that we have to know? Obviously, rivaroxaban, apixaban, and dabigatran cannot be used in pregnancy. The alternatives we have is fondaparinux in this case. Okay, remember that. Why can't we use this? Because this causes direct placental transfer of the drugs and can cause fetal hemorrhages. Okay, that's the reason we cannot use these three drugs in pregnancy. Along with this, we cannot use rivaroxaban, apixaban, and dabigatran also in patients with mechanical heart valves and liver dysfunction or hepatic dysfunction. So, I told you earlier why we can't use vitamin K antagonists, correct? Usually, we know in HIT we need the anticoagulation at the earliest, and heparin seems to be the culprit causing thrombosis there. So, already there is a prothrombotic state, and then at that particular time, if you initiate warfarin, that would cause worsening of thrombosis, and that's the reason we do not give it. Okay. On the same way, when we are talking about transitioning from an IV to oral, okay, so we have to be very careful, or else when we're transitioning between bivalirudin to ergotamine also, we should be careful. Okay. Usually these drugs are known to cause PT prolongation and they in turn can cause bleeding. Okay. So this is one thing that we need to remember. Coming to screening of asymptomatic DVT, this is where we need to think about long-term requirement. Okay. Initially, we might have looked in all of this, and then when the patient on screening at the time of admission would not have any thrombosis, but when you remove this patient's CVC and then you're sending them home for some other reason, they might require and they might develop a DVT at that time or a thrombus at any of these sites. So always screen these patients, check for development of new thrombosis. Okay, and if at all it is present, probably this patients have to be continued with non-heparin anticoagulation up to 6 months. So when do we transit to oral anticoagulation? A transition is always done when platelet count is recovered. Okay, so when you see that the platelet count is recovering, only then you can switch from IV to oral anticoagulant. Okay, another thing is when patient does not require any urgent procedures, even then you can think about transitioning from IV to oral. So duration, I've already told you, 6 months with thrombosis isolated, it is up to the point of platelet recovery. Most of the places, what they say is, despite giving these guidelines, both the British Society of Hematology and American Society of Hematology say at least till 1 month, definitely you have to do it in isolated HITT. Okay. What do we do in certain case specific scenarios like patients on cardiopulmonary bypass, etc.? All these patients again can develop, right? So in these cases, what they have told us, the alternative that can be used is bivalirudin. Okay, so if at all the patient has progressed towards remote hit or hit B, you can still think of using heparin in patients wherein we do not have any other alternatives available, but you should always be ready to diagnose it and treat it. Okay, so cardiovascular intervention is one tricky scenario wherein we have to keep a very close watch. Okay, so usually after 100 days, if everything is okay, nothing should happen. But if at all emergency arises, then we need to look at the case and go ahead by case scenario. The only thing, if it is happening between less than 100 days, where the probability of development of it is very high, the alternative is bivalirudin. What do we do in CRRT? Again, non-heparin anticoagulations like argatroban, danaparod, this can come into use. For the machine per se, you can think about using regional citrate anticoagulation. What is the role of IVIG? We all discussed that it is an immune mediated drug reaction, right? As of now, the evidence for IVIG is just based on case reports. Okay, so again, what is it focused on? It is hypothesized by saturation of platelet FC gamma 2A receptors. Okay, and here is where it blocks these receptors and inhibits the platelet activation, and thereby stopping the thrombogenic cascade. Okay, so again, this has been used in patients with refractory HITT only. Okay, again, along with this, any patient who requires emergency surgical intervention, even there, those patients, you can neutralize the antibodies using IVIG. The effectiveness is still questionable, but yes, in urgent surgical intervention, whenever you suspect HITT, give IVIG and probably then go ahead and do the intervention. Okay, so what are the differential diagnoses you have to remember for thrombocytopenia? That is bacterial sepsis, DIC, other drugs which cause thrombocytopenia like antibiotics, etc., hemolytic uremic syndrome, ITP, TTP, transfusion reactions, etc. Okay, so this is putting it all together. Suspect hit, calculate 40, get the intermediate or high probability. Go ahead, do a immune assay, functional assay, and check for thrombosis, no thrombosis. Thrombosis, 6 months of non-apparent anticoagulation, isolated hit, at least till platelet count recovers to normalcy. Okay. Remember when you're choosing your drugs, IV oral, no role for warfarin. Okay, switch from IV to oral when platelet count is recovering. Okay, always keep in mind the adverse drug reactions. Okay, so oral anticoagulations in pregnancy is a big no-no. Okay, so this is majorly about HITT, and this is the article that I was talking to you guys about. Okay, so you can take a screenshot of this and go. It was published in 2023. It's a very good review. Thank you. Any doubts?